Good morning from New York. December 18, I should say, 8 a.m. local time. Our webcast is a week early, specifically this month because of upcoming Christmas and New Year. But from the next month, January, we're going to resume as scheduled in the fourth week of the month, the fourth Wednesday of the month at 8 a.m. local New York time. Peripheral vascular interventions live webcast from Mount Sinai Medical Center, Cardiovascular Catheterization Laboratories, Mount Sinai Heart, in partnership with the American College of Cardiology. As you know, the functionality of the site allows you to view anything that you miss in today's webcast live. You can view it later on in the archives and at the same time pose questions. As well as review previous webcasts and pose questions with the same process as well. And the faculty, all of us will respond and continue the chat online as it evolves. You can always use the question function on the web page, even online, and I would be very happy to address these questions and pass it on to the live case operator team as we see fit and as the case evolves. And just to again welcome Dr. Peter Ferris, Chief Vascular Surgery, who will go and join us in the cath lab. And let's go over to the cath lab team, Dr. Krishnan, Dr. Wiley, Dr. Guja. Good morning, and we're looking forward to a very exciting case once again.
Well, good morning, George, and welcome everyone. It's really a great pleasure and honor to introduce our friend and colleague, Dr. Peter Ferris, who's our Chief of Vascular Surgery, who's kind enough to really come and support us in this tough case that we're doing. Again, Dr. Karthik Guja, our Interventional Endovascular Fellow. You guys have seen before. Dr. Jose Wali, our Associate Director. Dr. Nick, last name? I'm so Sikalis, who's our Vascular Surgery Fellow, is also here. And as always, Ray, our Interventional Nurse Practitioner, is here. Our nursing team is Elizabeth, and our tech is Ricky, as always. And again, I welcome you guys. I'm going to ask Karthik to present this case before I just share some thoughts on what's going on.
Good morning, everyone. Put the slides on for me, please. Right, so here we have an interesting case here. A 75-year-old male patient with complaints of lifestyle limiting right calf claudication on minimal exertion, about 1 to 2 blocks. Based on Rutherford class, he's class 1, category 3. He's Fontaine IIb. He's on cilostazol and has been on exercise program prior to presentation. His past medical history is significant for hypertension, dyslipidemia, diabetes type 2. He has a history of prior MI. He has ischemic cardiomyopathy. He is on nagranox, verapamil, hydrochlorothiazide, atorvastatin, fenofibrate, cilostazol, Zetia, and Combivent, and aspirin. He's a non-smoker, non-alcoholic, no history of IV drug use. Next slide, please. His vital signs on presentation were 146 over 72, 76 per minute. Again, he's 96% on room air, oxygen saturation. Physical exam is significant for his pulses being Doppler, bilaterally, DP and PT, with no evidence of tissue loss or erythema. Patient, because of his typical claudication symptoms, had an MRI as an outpatient, which showed bilateral SFA occlusions with distal reconstitution, and was sent here for peripheral angiogram. Peripheral angiogram showed borderline stenosis of the right external iliac artery, severe calcified long segment CTO of the proximal, mid, and distal right SFA, with the distal reconstitution of the proximal right popliteal via the profunda collaterals. The CTO of the right mid anterior tibial with distal reconstitution at the dorsalis pedis via the peroneal artery collaterals. Similar presentation on the left. There's a left short CTO with the distal SFA reconstitution. And again, mid-left anterior tibial CTO with distal reconstitution at the dorsalis pedis. So the plan here is to discuss about the endovascular approach towards long segment calcified SFA CTOs. Based on, we'll show you some pictures here. It's a TASC D lesion based on the TASC classification. This is a very long segment CTO, about 30 centimeters. So clearly it goes on to the type D lesions because it involves the proximal popliteal artery. So Again, based on the length too, it's a complicated CTO because it's a fully calcified SFA.
Yeah, very useful. This slide is very useful. It was a complex case presentation so far, so having a visual of the classification and where the patient fits is actually very fitting. Thank you, Karthik, and continue.
Thank you.
Thank you, George. I'm just going to go over the angio, and I'm going to turn it over to Dr. Ferries. What I wanted to show you is, immediately as soon as you see by the groin shot, it's got an extremely calcified lesion. Obviously, the common ferrules are calcified. The iliacs were extremely tortuous and calcified, but we had a little bit of difficulty getting up and over. But I want to just show you what we had done here. So we had taken a picture. As you can see, he was a little bit of coughing syndrome there. But as we inject, you'll see that he has heavily calcified common femoral disease with osteal common SFA or profunda stenosis. He also has a blunt stump of his SFA with a large collateral coming off the SFA. Go next, please. And you can see the SFA is long segment occluded. Next segment, please. And you can see here that he has a good above-knee popliteal, which actually would have been a very good bypass target, or maybe still would be if we failed this, where you can see that he has a good above-knee pop. And our goal here is, obviously, with the difficulty of the case, is try not to get too far into the above-knee pop. You can see that the popliteal itself is good, and the genicular collaterals filling the popliteal. Below knee, you see as an anterior tibial that's out, the posterior tibial and the peroneal are present. Next, please. And you can see that's going to be his predominant runoff to the foot. Now, George, normally in our workup, this was actually referred to us by one of our referring cardiologists. In our workup, we usually try to do physiologic studies. But this guy, with his history of ischemic cardiomyopathy, he was able to tolerate cilostazol. We started baby doses of cilostazol, 50 milligrams a day, and then titrated it up. Currently, he's on 50 milligrams BID. I don't really know what that's really doing to help him, but we're trying to do our best. But after we revascularized his left SFA, he felt phenomenal. So I just want to talk about the plan here. What we're planning on doing is crossing this device using one of the newer crossing technologies. But I just wanted to let Peter comment on what his thoughts were on the angiogram and our approach to using this crossing catheter, the crosser, to try to get through.
Well, also the dominant question is here, why not surgery, aside from the heart? We understand the heart risks, but perhaps Peter can also elaborate on the pros and cons of possibilities of surgery in this case, just based on the angiographic picture of the extremity. That would be very helpful for the viewers.
Well, I think that, thank you very much, George, for your comments and questions, and to Prakash for obviously arranging this case and this presentation. Surgery is certainly an option for a patient like this. His anatomy will allow that. When we are planning surgery, we typically will look at the conduit for the procedure itself, as well as the inflow and the outflow vessels. We prefer to use saphenous vein as the conduit for the bypass. That has the greatest long-term patency, the least risk of a infection of the graft material itself. And so that is the preferred conduit. That would require a preoperative study with duplex ultrasound to ensure that the saphenous vein were of adequate caliber and not diseased, such that it could be used for bypass. In the absence of that, in the above-knee popliteal segment, a prosthetic conduit could similarly be used. But we have adopted in recent years an endovascular first approach to these patients. We find that the morbidity of the endovascular approach is substantially less, and the capacity to alleviate their symptoms, whether it be claudication, such as this case, or a non-healing ulcer or rest pain, a limb-threatening circumstance, is quite adequate with the endovascular approach. The essential component of that, though, is to not jeopardize a potential bypass surgery. And in a case such as this, that would mean not using the subintimal dissection and extending it down into the potential target for bypass. Here, the target for bypass would be the above-knee popliteal segment. And what Dr. Krishnan is obviously very careful in doing is not extending that subintimal dissection beyond the target area for bypass. And if need be, use a re-entry mechanism at that level, at the above-knee popliteal level, whether that be an anterior or an outback or a pioneer. So one of the re-entry devices may be necessary at that level, so as to not extend with the wire down into the target. If you do that, then when you you go to sew the bypass graft, you make an arteriotomy, and the vessel itself is dissected at that level and not suitable for bypass. This would be a good bypass case, as it is a good potential angioplasty or atherectomy case, because the outflow is so good. You have very good two-vessel runoff from a reasonably healthy popliteal artery.
So, George, I think those comments are incredibly helpful, and I can tell you that right now, what we're using is this catheter, which is a catheter called a crosser catheter. Little fluorophate, please. Inject. That's it. He's got cardiomyopathy. Okay. So you can see he's coughing from a CHF. But the point here is that the two things that come into play. I'm going to start with this catheter, which basically pulverizes the cap of the occlusion, speeding up micro bubbles and acting as sort of a drill to be able to drill through. So we have a support catheter which comes with the device, which I'm not going to. I don't know the name of it, but the point is it's got a braided tip, and it's got, as you can see, a pointed tip, so you can direct it away. So what I've done, if
direct it away from the side branch.
The side branch, you can see here, fluoro.
That's a very clear. That's actually a technically difficult.
Right.
CTO exactly because at the edge of the occlusion.
Right. But
also a side branch.
There are two other things that are very important with what Dr. Ferry said. You have a profunda involvement and the ostial SFA involvement. So therefore, our threshold of sending this patient for a surgical revascularization is going to be much lower in this particular case, because what our plan is going to be once we get through is to possibly stent the SFA, but possibly atherectomize the ostium of the SFA and not touch the ostium of the profunda. If the profunda should become compromised, we're going to convert this guy, for all of you watching out there, from a claudicant, although albeit a severe claudicant, to now limb-threatening ischemia, which is what we don't want to do in these particular cases. So therefore, the collaborative approach is always good. So I'm just going to go ahead and ask them to start. Press the button, guys. Start the device. You're going to hear a little beeping. Go. I don't know if you can hear that beeping, George. So you can see here I am absolutely not putting.
You can see it advancing though very nicely.
I'm absolutely not putting any pressure here, George.
And avoiding the side branch, very important.
Well, I'm just, and Dr. Ferry is just going to help assist this. It's a little bulky in terms of how it moves. So I'm just going to put a little bit of pressure here and allow it to just jump forward, and letting it work through. It can be quite challenging here. I'm going to ask Dr. Guja to advance that catheter slowly. Whoops. Okay, it times out. Go ahead, Pete.
Yeah, I was just going to say, we've used this crosser previously, and I think it may be better at staying in the luminal component rather than the subintimal component of the vessel. So that may be advantageous when it comes back to re-entry.
Start.
And even if it just directs you for the first centimeter or two and then stops going, it's not the end of the world, because then you can use your wires with greater safety and a greater chance to, first of all, there's no chance for your wire to inadvertently keep going in the side branch or buckling in the side branch, which is the first technical hurdle. And the second is that it may continue as you enter in the straighter part of the SFA. It may continue just straight up on the pathway of this crossing device.
Okay,
so it's not obligatory that you cross all the way with this device. That's what I'm trying to say. Even if you just pave the beginning, maybe prove quite beneficial.
You can see that the calcium is so difficult that actually it's not breaking through this. I'm just going to sit there and let it work, and you hear that high pitched chirping, which again is showing that I may be getting a little subintimal here. So obviously the techniques of crossing here are to use a crossing catheter such as a crosser, or multiple others that are available. We obviously, let me just go over briefly that. Maybe Dr. Ferris can talk about some of the catheters that are available. Go ahead, to try to be intraluminal as you cross.
Yeah, I mean, sort of our first approach traditionally had been to use a hydrophilic wire like a glide wire, usually an 035 wire. Very commonly stiff glide wire, so you had additional support. But there are other devices like the front runner that can be utilized. But calcium is really the biggest challenge, I think, and I'd be interested in your feedback on that as well, Dr. Krishnan. But calcium in the occluded segment can be very problematic.
Off-road map. Well, this is clearly, you can see here, Peter, it's off-road map, guys. you can see that it's really you know, a very challenging case because of the calcium, as you said here. But it is starting to move. I don't like the way this is deflecting, and I think for everybody watching at home, you want to see how the catheter goes on, guys. You want to see how it moves. So you know the track of the SFA, right? That is not the track of the SFA. So what you'd like to do here, off please. What you'd like to do here is to try to torque the catheter into another plane, which is what I'm going to try to do here. If the catheter torques. On please.
You know, we used other devices such as the Viance as well, but that really does not do well with the calcified.
Not at all. Not at all. I think this is the important part of it, is that you need to understand the technology, how it works, and then figure out which one works well for your particular case. In this particular case, I mean, when myself and Dr. Wiley were talking about it, it was either going to be a successful cross using this device, or it possibly would be using your traditional wire techniques. On, please. Mm-hmm.
I think you're already about 25 millimeters into the occlusion, or something like that.
Yeah, but you can see, George, it's not helping us at all.
So it's actually, that's a bit more than a few times that
and you can see there's a hunk of calcium right there.
Took me over to like about 10 or 15. So I think that's quite a bit of advance here.
See, and you don't want it to deflect off and go in a different way, because like Dr. Ferry said, we have different modalities that we can try. So we're going to give this a good old college try. Put the timer on, please. On. So I usually use a timer in these kind of cases, George. We give this a good 5 to 10 minute attempt, and obviously it's extremely challenging for any device, let alone you know, this particular catheter. So we're going to try to just kind of wiggle it through, and you can see right there seems to be the major issue here. No, let's go more medially now. On again, guys. Pull it back, Karthik, a little bit. There it is, like that. Any thoughts, Peter, on anything you would do different here?
No, I mean,
catheter?
you know, I think that chunk of calcium is just sitting right in the midst of the vessel, and
right.
So if this gets through it, I think that'd be good. But like I say, a Viance I don't think would work in this circumstance. And even with a wire, we're going to have challenges. The calcium really is a tremendous limitation for subintimal or recanalization of an occluded segment.
Yeah.
And I don't think this device has the capacity to do it.
I don't think this is going to work. We're going to pull this one out. Can I have a straight glide, please? Let me see where we are. And an angle glide. Give me both. So now we're going to switch to our standard technique here. Now, Peter, having your experience, obviously, in this type of case, you have a guy who's a severe claudican, who's got common femoral disease, who's got osteal profunda disease, who's got a good target, okay? So what is the acceptable surgical risk in terms of our postoperative or perioperative risk here for you to treat this guy surgically if we fail? Or what would you estimate his risk to be?
Well, I would, in a patient such as this who has ischemic cardiomyopathy and extensive comorbidities, I would really encourage him to try to tolerate his symptomatology if I could not achieve revascularization and with the endovascular techniques. Mm-hmm. I would reserve in a patient who presented with this constellation of symptoms, I would reserve bypass for someone who progressed to a potential limb loss situation. In other words, if he developed breast pain, he developed an ischemic ulcer or a pressure ulcer, then obviously we would revascularize him for limb salvage purposes. But in the absence of that, the likelihood of his claudication progressing to limb-threatening ischemia is about 1% per year. So a very low likelihood of progression to limb-threatening disease.
Tip of the catheter.
And if it were to progress at that point, then obviously we would offer him bypass.
So the bypass option is only, so how would you deal with this, Peter, if like our plan, if we were able to get through, right, was to atherectomize the ostium and stent the distal or whatever it may be?
Yes.
So the issue is, well, how would you deal with that ostium and how would you avoid that profunda?
Well, surgically you have a couple of possibilities. One is to dissect out the deep femoral as well as superficial femoral and do a endarterectomy extending down into the deep femoral, and then take your bypass graft off that same arteriotomy. Use that use the common femoral as the inflow. But if it's truly a limb-threatening lesion, you may want to just work more proximal to that. Attempt to use the common femoral exclusively for your inflow. And in doing so, avoid manipulation of that profunda, because you're gonna, if you achieve straight inline flow back to the level of the above the popliteal into the calf from there, I think you're going to alleviate the symptoms, as well as if there were a non-healing ulcer, achieve adequate tissue perfusion to allow that ulcer to heal.
So advance now the catheter in the subintimal space past the obstruction, and PK is using a N-hole 4 French catheter. And
give me a straight glide, guys.
A glide and an angle glide, which took him just about to the area where the crosser was, and now we try with the straight stiff glide to see how it goes straight on the highway.
I think we're trying to get through this calcific chunk that Dr. Ferries was talking about here. And I think that's the issue. And you saw the complexity of that common femoral. So, this is one really tough case. The other option here, Pete, is what about the option of a hybrid case? If we are lucky enough to get through this, could we send this for endarterectomy?
Yeah, absolutely, especially if he did not get alleviation or complete alleviation of his symptoms. And the morbidity of a femoral endarterectomy is substantially less than of a femoral to popliteal bypass.
No, don't push, please.
So the patients do tolerate that well, and those procedures can be done under epidural anesthesia if there's pulmonary concern, and there may be in this patient, just given all the coughing that he's been experiencing.
Yep, you can see that. And the issue would be whether we can do it on he's quite a skinny guy. The other question, guys, is, and a question to Dr. Ferries, as you see us struggling here, is what about if we cannot get through this? Would we be able to, would he get alleviation of symptoms if you either what is it called, fix the profunda percutaneously, or do an endarterectomy to just fix the profunda?
It's a good question. I think he would certainly, the profunda collaterals, and you demonstrated that well with the arteriogram, the profunda collaterals supply the below knee popliteal quite nicely. And so by opening up the profunda, you would certainly improve blood flow to the gastrocnemius and soleus muscles, and I think you would see substantial improvement in his symptoms of claudication. Usually that's not enough to heal an ischemic ulcer, but for the symptoms of claudication, that may well give you substantial improvement. And then I think you'd be talking about sort of a risk-benefit ratio. So what's the risk of the surgery versus the benefit in terms of his ability to ambulate, and what's, how great is his need for ambulation? In other words, is he a postal worker who walks around the neighborhood for a living and requires that to be able to perform his job? That's part of what weighs into it. And if you're talking about atherectomy of the profunda origin, then you just have to concern yourself with whether you could potentially be initiating intimal hyperplasia and ultimately lead to progression in that lesion. So it's a consideration, but it's a very focal area, and it probably would respond well.
The other thing is, can we try the Boston TruePath here, please? So one of the advantages, obviously, for working with a place of this institution, we're able to have a lot of different catheters. So one of the things I'm thinking here, since we're hitting that chunk of calcium, whether the TruePath catheter, which is a drill bit type of catheter, may be able to get us through this calcific nodule that we're hitting here.
Yeah, and some people will use laser in that circumstance as well.
Right. I think we're going to try with the TruePath first and see how it goes. Guys, can you get the TruePath quickly? Pete, any other options here you think other than trying to jam this wire?
No, I think something that can give us a more substantial drill like the TruePath or potentially laser is a consideration. But I think this really highlights the true difficulty that severe calcification engenders as far as revascularization. And it makes open bypass hard as well. If you could visualize the level of calcification in the common femoral, It's a vessel that would be hard to clamp. You'd have to find a soft spot to make your arteriotomy for your inflow. So calcium is a really problematic both for endovascular and open repair.
And that is a very important point that Peter just made, because if we pan a little bit higher, we can see that the entire arterial tree in the femoral and iliac, inclusive of the ostia of the profunda the SFA, is heavily calcified. So clamping and having adequate control of this area surgically might not be so easy.
Well, you can see here, George, it's this chunk that's really stopping us, and that's one of the reasons we wanted to show this, is to really show you the difficulties that you can face with difficult lesions.
You want to try the back of the glide wire, PK?
Well, like I guess we have done that in extreme cases, but I think like Dr. Ferry says, he's a claudican here, and I think we do have some options that we've discussed. So I think we before we get heroic with that stuff, what I would do is probably go ahead and try some of the other things that would, like the TruePath and other sort of technology that we have available. So right now, Dr. Wiley is trying to get this Confianza wire out for us, and if not, we'll just go ahead and use the TruePath. Now, the TruePath itself also does the same kind of thing that the Crosser tried to do, except it's more of a drill. Since it's more of a drill, it'll actually help us to be able to drill through. Ray, can I have the TruePath, please? So I'm going to go ahead and take the TruePath down since it's available. And what we're going to do is just go ahead. It just plugs in. It's very easy setup. It has a little torquer, and I have this torquing a catheter there, the Aquatempo catheter, which is going to help us. TruePath also gives us audiovisual responses with this beeping sound that tells us if we're intimal or subintimal, and you'll see it come. There it comes in wire. So I'm going to put it up against this. Go ahead, start it on, guys. So you can see it's going to start to drill. I'm just going to hold positive pressure. There it goes. He's already starting to make a little bit of a headway, and now that's telling me that it's going subintimal. So let's try again. Subintimal is really not the problem. It's more about trying to.
You gotta go through the calcium, and then we'll figure out.
Right. That's exactly what we're trying to do. Follow, guys. Who knows where we are? The good Lord does.
One somewhere.
I said the good Lord knows where we are, George. Okay. Then we're going to stop here. We're going to advance this catheter. Okay, let me see it, my friend. A lot of times we have a lot of trouble advancing these catheters through these tough calcific. Hold it, Jose, wire for me. Does not want to go. Look at that.
No, you may want to go with you may want to go with a smaller.
O&A Trailblazer, I agree. I just like the directionality of it. But I'm going to go ahead and, we made a little channel here.
Oh, watch it. Yeah.
So I'm going to have to take out the whole system again and start again here.
Why?
Okay, look, we made a little channel. Start again here, Jose. I'm just going to try to make multiple holes here. Try to get the 035 through. Keep going.
Well, instead of taking it out, you may just take it out and try the straight glide again.
You got to press it. Nope. All right, let's try the glide again. Straight glide. Try to perforate this cap and try to get through. Yep. Hold this, guys. Okay, let's just give a little dive from above to see where we're at in terms of our plane. That's enough. Okay, we're okay. Not horrible in any way.
Now, when you get through on these, with this long segment of occlusion, there's a propensity for restenosis. Prakash, you've been the principal investigator on a number of drug-coated balloon trials. What's your feeling about drug-coated balloons and the potential role for those in a circumstance like this?
You know what, Pete? I think in this particular type of lesion, TASC D, they have not been studied in a randomized control fashion. Obviously, you and I and people like us here who are doing a lot of these cases hope for a better result. But right now, I mean, there has not been any studies with drug control balloons in these long segment lesions. The lesion lengths have been, the maximum lesion length that's been studied in America has been, I believe, 140 centimeters with both the Lutonix as well as the Medtronic as well as the now the new trial. However, the Zilver PTX, man, this is just something. The Zilver PTX trial has a registry, at least, and Karthik knows the data very well, has actually 150 millimeter lesions that is randomized in the registry arm, although the PTX arm only randomized 80 millimeter lesions. So, Pete, I think that the data is sparse, and we're trying to showcase different techniques here, but it's not working. At this stage, we're getting very frustrated. No problem, willing to admit it. Can you give me a little dye up top, please? Let's do a roadmap. So what I do in this kind of situations at this time is go ahead and try to find another plane. Inject, please. Okay, good. Ready? Show me above, Karthik. Let's try to go another plane. I'm going to take it to this side here. Let's see whether we can get into another. Ooh, this thing is so dry. The other thing also is to keep your equipment moist, right? And sometimes what you might be able to do is try to create a subintimal plane from here. And you got to be very careful while you're doing this, guys, because the point is you don't want to, look at that, it's not going anywhere. Wow. Okay, advance the catheter, Karthik, here. Okay, hold it there. Oh, wow, my goodness. Wow. We've met an SFA that's given us a lot of trouble here, huh?
Yeah, and I always am concerned when I see the J on the wire being very wide. That suggests to me I'm pretty far subintimal, almost subadventitial.
I agree here. It's not a.
I'd like to see a nice narrow.
Let's get a front runner here, guys. So we're going to try another device called the front runner device. This device is a Pac-Man sort of device that will open the jaws and try to cause subintimal dissection. Go ahead, a little die. Okay, let's see here.
Well,
yeah, you can try that
the
too.
target is outlined very clearly. Just have full of calcium. I think that may be a good case for this Pac-Man type device.
But George,
you got to go straight. It's just that it's extremely hard.
Yeah, George, you can see that, like what Dr. Ferries is saying, the difficulty we're having breaking this cap. I mean, it is quite difficult to, you see it right there, is not a favorable kind of design here, the way that loop is so large. And you can see the difficulties we're going to be having with this. What I'm just trying to do is just to see whether I can just somehow, get through this initial calcified part, and I'm hitting that chunk again. I mean, you can actually feel that, the buckle that we're having. It's quite difficult. So let me try the front runner, pull it back again and try the front runner. And then the other thing we can do is think about other novel access points, not that we're going to do it in this particular case. We're going to pull this back here, guys, right there. So we're going to think about laser to go down, and the question is whether we open the laser. And now the other issue becomes the cost of the case. Now, as we know, we want to be economically feasible here in terms of what we're trying to achieve. So this is a very difficult case, obviously.
I like the word feasible, PK, because we're already expensive.
We're expensive, for sure.
Open,
Jose.
That's great.
Wait, hold on. Open now. Here, open. Track the catheter, Karthik. Okay. Yep. Okay. So this, Ray, go to coronary here, so we can demonstrate how this thing works. Okay. So you can see here, guys, mag up nicely, please. So what you want to do is you want to put positive pressure on this and then pull back.
You can collimate a little bit tighter, Jose, so we can save a little radiation.
Okay. Oh, I agree, and that should be economically feasible too. So pull the catheter back slightly, please, Karthik. So you can see I'm jamming it into that plaque and then trying to open the jaws and pull it back. And unfortunately, it's not opening and it's not going anywhere, as you can see. So we're really having one hell of a time here. Track the catheter forward, please. Okay, that's perfect.
Yeah, and I think that's the exact same spot.
Yep, exactly, Peter.
Yeah, it's a 5 1/4.
What's that, buddy?
5 between 5 and 6 is really the main bulk.
You want to try the laser?
Has an articulated jaw, so it's like doing a dissection.
So I'm just Well, as Dr. Wiley opens, I'm pulling it back and then closing, and then going forward, pulling back and closing, forward, pulling back, closing. Cannot, this is one tough plaque, George. Down, okay. Now let's try, go scene minus Ray for me. Hold the catheter forward, Karthik. Yeah. Hold it. Give me the confianza now. Now that we're through with this, we have a little bit of, I just want to see if there's any transcollateral approaches that we can try. Let's see the collaterals to the I wanted to see that. Thank you. So you can see that the profunda is giving collaterals right there, and there's no real robust collateral channel that you'd be comfortable putting a catheter in. Yeah. So a lot of times here you can look at a transcollateral approach to try to do this, but the thing we may do here is ask Dr. Ferries to bite the bullet and see what he thinks about a bypass, because this is one where obviously we're going to keep trying for another 15-20 minutes in the scope of this case.
I would probably try the back of the wire before try the laser.
Okay. You want to be
right there.
You want to be cost conscious.
Exactly.
Wow.
Because the front of the wire, they behave better. They behave the same, whether it's an angle or a straight wire. Somehow they both look extremely angled as soon as you put them in there.
So, Dr. Ferries, what do you think about the back of the wire approach here?
I've been reluctant to use that.
Yes.
I've done it occasionally, but that tends to find its way out of the vessel.
Especially,
I mean, you could try it for a short distance just to get through that calcified segment.
Yeah, exactly. I would say just for 1 millimeter. If we can go to 7.
But even after we're through, we'll still run into issues with tracking catheters and being able to get an adequate luminal expansion with the balloon. I mean, this calcium is really, truly problematic for these patients.
How about a wireless rotablator? Have we invented that yet?
Not yet. I mean, that's for sure. I mean, not yet. We have not done that. But this particular case, I mean, you can see the challenges we're having. Ah, there we go.
The Rotarudo.
Advance it a little bit.
The real Rotarudo.
Hold it there for me. No, we're just trying the 014 to try to make a channel and then see whether it goes through. This is the Estado wire. Okay, let's see. It's doing something. I mean, obviously. I know we're not going to do. I don't think we're going to do the laser here, Liz. You can't advance the catheter anymore. We're there. So, give us the. You know what? Let me try the V18 here. Let's try the Viance too. Let's try the Viance. Let's pull out all stops here. Let's try the Viance catheter. Any other thoughts, Pete, before we...
No, I mean, my thought is that if Dr. Krishnan can't get through, then it's not possible. That's my principal thought. But you're absolutely right in considering the economic considerations. At a certain point, if you're utilizing this number of devices, it does become a constraint on your ability to really do the case.
Yeah, and that's what we're saying. I think that here, we've done. Look at this catheter, how it's buckling. Look how it's being treated.
It's buckling right off.
This is not something that I mean, everybody hates to fail, especially live, and the point is here, the issue here is the question of what's best for the patient.
It is interesting that it's a dense fibrocalcification without a tremendous degree of adventitial calcification, because we don't see anything tremendous fluoroscopically.
Track the catheter a little bit. And you can see here, George,
it's extremely hot.
You can see how it's pushing my wire laterally.
Yeah.
That's what I see. I mean, I've done thousands of these cases now, and I can tell you that is really, really, really something that's surprising. So, we looked at, so the other thing here is obviously that one we do not advocate, but if it was a critical limb case and you had to get through this and it was not any surgical options, is possibly a pedal access and come back up from below, snare the wire. But I got to tell you, with all this complexity that's going on, I think for this kind of case, it's not going to work.
No, I would agree with that. If you're having such a problem with the proximal SFA, that's not a good start. If this was happening right above or close to the distal cap, that might have been a consideration. But you're just now on first base. having problem, holding first base. You don't want to, embark on any heroic measures of that sort with a distal circulation.
Well, I think it's interesting because the Viance catheter is another form of drill that tries to find these microchannels. And you can see here that as much as I'm drilling, there's no microchannel that it's finding. You
can hear it clicking,
yeah.
So it's disengaging when it does that.
Exactly. It's not exactly doing what it's supposed to be doing. So this has become, maybe see, there it is again, is disengaging. There you go. Yeah, a little more support with the wire. Nope, not working here. The only other thing I can think about is a laser up front and then blast through and see if that helps.
That we need an 014 wire to go through.
Well, we have all that. We can easily.
Yeah, no, I'm just saying.
We can actually switch this out and do it with an 014 wire. Pull the catheter wire back, please. So sometimes you pull the Viance back and try to let it find the lumen, and you can see, like Dr. Ferris is saying, it's disengaging. No use. Nope, it's not going to go. So the question here is now, we've got 15 minutes left. What are the other choices that you guys would try with all your experience? We know surgical bypass is the option, and we talked about that early because of the complexities that we felt this case offered. The other issue is, Peter, what else do you think here other than that?
Well, I mean, the Safari technique that you talked about is a consideration. For claudication in a patient with this degree of calcification, even if you get wire access, you're still going to have a lot of difficulty being sure that you're going to get good resolution of the stenosis and good revascularization. So I might be a little reluctant to pursue that in this patient.
Right, right.
And I probably would also hold off on bypass just given their comorbidities. Now, you had highlighted the potential of atherectomy of just a profunda lesion, and the profunda collaterals are quite good to the, as you demonstrated, to the above knee popliteal and the at knee popliteal. So that is certainly something that you could consider performing to get a moderate improvement in the... Because
he's a severe claudicant, Pete.
Yeah.
He's, I follow this guy, this gentleman in clinic, and I can tell you his claudication is very lifestyle limiting, half block, not even, and he has to stop. So if we were able to, increase the flow into the profunda by endarterectomizing the common femoral, which we've done in the past when we have no other option. So I was thinking maybe that may be something that may be able to help him.
I mean, you may take him from, a block or less than a block to 4 or 5 blocks. And that, if you think of the lifestyle change that results in, it's very substantial.
Oh my goodness, absolutely.
Remember about 10 years ago?
The other aspect here is that I would look more carefully if there's anything that contains a gradient in the iliac circulation. And perhaps end the case with some type of intervention up top, because that might also improve the claudication. Sometimes we have smooth-looking calcific 56% appearing lesions in the iliac circulation that they could have quite a bit of gradient. So we might want to do a selective up there.
Can you show me the iliac? We don't have an iliac shot here. We had it before.
Yeah, we could do a pullback gradient or
That's that's a good point, George. Why don't we do this? Why don't we give me a 035 supercore here? Let me pull the sheath back, and then what we'll do is we'll do a straight catheter pullback of the external iliac. There might have been a borderline stenosis at the time, and we'll take a look. And then I think at this stage, I don't know, unless Dr. Ferris has anything that he thinks we should try. I want to stop short of the laser here just because of economic considerations, and I know that that's not necessarily the thing, but I do not think it's going to be work here. George, what's your thoughts on the laser here? Can you put positive, please, on the catheter? What's your thoughts on the laser here, George? Trying the laser.
I think it's an option, but I'm not sure you're going to go very far because, again, this is the proximal third, if not the proximal fifth of the CTO. We have so much problem in the proximal fifth, then we still have 4/5 to go, even if we are Yeah, if you pull the sheath back up there, you can do essentially a 2-transducer pressure gradient that might, you know.
Well, you know, the problem, I can tell you, the problem here is that you have a large sheath obstructing a relatively small iliac. So the ideal way to do this is to actually do a true pullback from the common femoral back with the sheath back up and over. So that may be the only way to do it, but we'll do a poor man's pullback here to see what we see. So we're gonna switch this out. Walk this out, please.
Yeah, the other consideration is your outflow is occluded, and so there may be a hemodynamically significant stenosis that is being masked by that outflow occlusion, by the lack of outflow.
Right.
So you could theoretically give a vasodilator, but a lesion may still be significant even if the gradient is not substantial if the outflow is occluded.
And you know, for the audience, you know, you've seen in this case, the beauty of this case here is, you know, all the challenges that we all face as interventionists. I mean, Dr. Ferries, myself, Wiley, Dr. Dangus. You know, this is a case that's extremely difficult. So, you know, we're collaborating, trying to figure out what the right thing to do is, and thinking about other ways since this patient is not an ideal surgical candidate. So, you know, just to reiterate 2 things. 1, we talked about obviously the techniques of crossing, different catheters used for crossing, and two, we're now talking about other things that we may be able to accomplish in order to help this gentleman feel better.
Maybe we'll do a selective iliac injection or something as well.
Well, let me just do a little pullback gradient here, George. Like Dr. Ferry says, and see what we see. And you know, we could do an iliac stent. That's not an issue. Flush forward, guys.
You know, Prakash, remember about 10 years ago there was a paper, Silva and
Okay, good.
that has shown that
0, please. Flush forward.
profundoplasty was actually a reasonable alternative in patients where the SFA cannot be reconstituted via endovascular surgical repair. So I don't think that would be an unreasonable
We don't hear very well the mic of Dr. Wiley. I think we have.
So we have a baseline.
Let's look at the gradient.
So we have a baseline. Again, I have the catheter up and over, guys. So you're going to get a muted pressure gradient here. So
hemodynamic screen, please.
So the hemodynamic screen just shows around 110. Just going to slowly walk it back. You can see it's respiratory there. Well, there may be a gradient there.
Maybe a little gradient there.
Well, there's 10, 15. Wow, it's a 130 right there.
Yeah, look at that, 140.
Not really, though.
Not exactly.
No, is there? I don't know, Peter. What do you think here?
I think there probably is a gradient
Take a
there.
shot.
It looks to be, at least for the systolic pressure, about a
DSA?
20 millimeter gradient.
Yeah, we're just going to do a little DSA injection just to see what we have. Nope, nothing other than tortuosity. There is a little bit on the external iliac you can see there, distally, but I don't see anything major. I think it's more tortuosity that's causing it. So I mean, we didn't notice anything on the initial angiogram that we did.
There is something that external iliac there. Could there be an eccentric lesion down on the, you can see it in another view maybe?
No, we can do another view, George, but I mean, I did review the iliac, and obviously one of the tenets that we've been teaching here in the ACC course is always fix the inflow before the outflow. So I would be shocked if we missed this, but I mean, anything can happen, I guess. Inject. You know what I'm saying? We've been teaching that left and right. So you can see there's really nothing in the iliac. So, I mean,
Profundoplasty or?
well, you know, Dr. Wiley is thinking about profundoplasty. I've got the chief of vascular surgery next to me. I've got the luxury to ask him that question. I personally, on my opinion, for a claudican at this stage, I would not, but I just want to see what Dr. Ferries has to say about that.
No, I agree. It's definitely a consideration, and you would take into consideration surgical risk, the extent of the debilitation the patient experiences from the lesion. But I think given this patient's risk, I would probably defer for the time being and continue to treat him conservatively with medical therapy as well as exercise, supervised exercise program, and see where things are. The other thing to instruct a patient, though, particularly the patient with diabetes, is very careful foot care because the diabetic has the neuropathy that predisposes them to neuropathic ulcers. And if this patient doesn't get an ulcer in his foot, the chance of limb loss is very, very low, about 1% a year. But If he gets an ulcer, then he'll be in a limb-threatening circumstance, and you're going to have to revascularize him. So it's important to speak with the patient as well about not getting pressure on the foot, not wearing tight shoes, not going barefoot on the beach, etc., so that they don't have an ulcer or a traumatic lesion that forms.
You know, I want to thank Dr. Ferries for those points, because I think a lot of times interventionally, I mean, as a vascular surgeon, he takes care of these feet all the time. As interventional cardiologists, we tend to forget the importance of all the things that he highlighted. And and a lot of times we learn more from failure than we learn from success. And and in this particular case, I mean, I just want to just kind of recap what are the things that we, all the three of us, and George Dangus and all our team here hope to get home to you guys watching. Well, first and foremost, I think angiographically, this particular case presented challenges from the moment we started. And let me highlight from one to one. So first and foremost, the iliac angio, which you did not see, was very tortuous. So crossing up and over was a challenge, but we did that safely. So that's the first safety consideration. Second consideration on angiography, you saw it, Ray, can you go to the angiography as we talk? Can you go to the common femoral shot? So the second consideration, the moment you see the common femoral picture as an interventionalist out there, you have to start understanding the importance of this particular picture. This particular picture shows two things. First and foremost, that the calcification is going to present an extremely challenging intervention. I mean, among the three of us here, we've probably done well over 10,000 cases, and I can tell you that you saw a struggle in this particular case. So the calcification here automatically is an indicator of difficulty. Second, you see profunda and SFA involvement. So that, as an interventional cardiologist, should strike in your mind that while you're doing this, if God forbid you plaque shift into that profunda, God forbid you dissect the common femoral into the profunda, shut the profunda down, you are now potentially making this patient worse. So automatically the care has to be taken when you approach this patient. Next slide, please. So when you go down and look at the distal runoff, the second thing that you have to highlight to yourself is, well, I have a great above knee popliteal. Next please. The above knee popliteal tells you that the patency, regardless of PTFE, although a vein is the best, as Dr. Ferries highlighted, regardless of PTFE, could be acceptable if this patient is a good surgical candidate. So therefore, your goal, if you're lucky enough to get through avoiding the pitfalls of the calcium and the profunda and the difficulties that we faced above, you do not want to extend this below this above knee popliteal too far. You do want to give the surgeons a good target and not to cause the patient any further harm. Next, please. The third thing that you can see here is that its below knee runoff is quite good. So that actually pertains, again, Dr. Ferries will correct me if I'm wrong, pertains to a favorable outcome surgically much more than interventionally. We do know that interventionally with these TASC D lesions, the patency rates are very low, as Dr. Ferries did discuss. And however, as you do know, that endovascular first has been what we've adopted not only in Mount Sinai, but in all different institutions throughout the country. Exactly. The most important thing in these kind of cases is to have a collaborative approach. The collaborative approach is a win-win for you, the institution, everybody involved, and especially the patient. So I think in this case, I mean, we've got different thoughts of, we also went over the different devices. We went over the approach using the crosser catheter. We went over the true path catheter. We talked about the different wires that were available, the subinterval technique. We also talked about the use of the laser, which we did not demonstrate in this particular case. If we had crossed through, we would have talked about re-entry devices, which I think we're going to stay away from at this particular stage. But I think as a nutshell, the important thing is to point out what Dr. Wiley brought up, is there may be an option of a percutaneous profundoplasty. Now that, as Dr. Ferries clearly outlined, was very, very clear in the sense that is more for an extreme case and not so much for a claudican, albeit a very lifestyle limiting claudican. So even in this case where we failed, and no one likes to fail, but the point is that we clearly were able to give you a lot of teaching points and a lot of things to ponder upon when you see the SFA in your practices. Again, Dr. Ferries, it's 9 o'clock, so I appreciate your time, sir. Thank you so much for taking the time and really spending. Nick, thank you as well. And again, George, I thank you for this great year of moderation and for everything that you've done, all the good folks at the ACC. And we're lucky enough, Dr. Ferries has a lecture planned for us, which will hopefully highlight some of the things that we're going to do here. So we're signing off from Mount Sinai to 2013. Again, with them all thanks to my team, Elizabeth, Marichu, Ricky, Carlos, Ray, and of course my interventional fellow and dear friend Karthik Guja. So thank you again, Dr. Wiley. Thank you, guys.
All right, and Thanks for the interventional team and Dr. Ferris for joining in with his surgical opinion as well as endovascular experienced comments regarding this highly complex case that was, in brief, had to do with extensive iliofemoral calcification, inclusive of the osteo of the profunda and the SFA, as well as a very long TASC D, complete occlusion of the SFA, essentially from like maybe 20 millimeters from each ostium all the way down to the canal. Pretty good runoff, however, unable to cross with multiple, I think 5 or 6 permutations of different interventional devices, exhausted this option. I think this was an extremely informative case, and I would like to thank our viewers for their input, which I passed through the couple of times through to the operators, and that exchange was great. This case might be particularly interesting if the viewers want to continue sending some questions regarding either the devices or the general approaches used in this case through the question tab or the webcast window. And I will also let everyone know that after the end of this live case, you can go to archives and view the details of this case as well as previous cases along with the related chats. Let me remind everybody that the next webcast will be at 8 a.m. New York time on Wednesday, January 22nd. And I would allow everyone to have the best wishes for a new year 2014 that will join us between now and the next webcast. Goodbye from New York.